Okay. Uh, so okay. So can you go down and let's see the answer? Hannah, can you move to question number 2? Yeah, the next slide. Can you go to the next slide so we can see the answer? Okay. Can you make it little up the screen so we can see the answer? Okay, I'll read the question again. A 42-year-old woman comes to the office with a 4-month history of heartburn. She describes a periodic sticking sensation in her chest during meals. In addition, the patient has recently been unable to participate in her normal exercise due to dyspnea on exertion and joint pain in her hands and feet. She does reveals bilateral and inspiratory crackles. Endoscopic evaluation shows mild hyperemia in the of peristaltic waves and lower esophageal sphincter tone. Which of the following is the most likely mechanism responsible for this patient's venometric findings? A. Dysfunction of inhibitory neurons. B. Eosinophilic infiltration of esophageal mucosa. C. Loss of intramural neurons. D. Smooth muscle atrophy and fibrosis. E. Striated muscle inflammation. Okay. So most of the people saying eosinophilic infiltration. Okay, so we have question number 2. A 25-year-old woman comes to the physician complaining of a skin rash and pain in her wrist, ankles, and elbows over the past 4 days. She also has a fever and sweat but denies headache, nausea, or vomiting. She has no significant past medical history and does not take any medication. She recently took a vacation with her new boyfriend. She denies any previous sexual transmitted disease but acknowledges having unprotected sex with her new boyfriend. She does not use tobacco, alcohol, or illicit drug. Her temperature is 38.5 and her pulse is 98. Her oropharynx is clear and there is no thrush or lymphadenopathy. Her abdomen is benign and the pelvic examination is within normal limit. She has pain along the tendon sheets with active and passive hand movement. A photo of her skin rash is shown below. Which of the following is the most likely cause of her symptoms? Lyme disease, syphilis, gonococcemia, meningococcemia, acute HIV infection, acute rheumatic fever. Okay. Okay. Yeah, I think so. Yeah, there's a history of vacation. So yeah, most probably could be aligned with these. And what else? Anyone has any other option?
I'll go with the gonococcal infection
Okay.
because she has a history of unprotected sex. And Lyme disease has a very typical skin lesion, which is, I don't know the name at the moment, but it doesn't look like Lyme disease to me.
Okay. So more answers, or let's check the answer. Let's see the answer. So yeah, the answer is gonococcemia. Yeah. Okay, this patient has the classic triad of polyarthralgia, tenosynovitis, and painless vesiculopustular skin lesion for disseminated gonococcal infection. Her complaints of wrist, elbow, and ankle pain are consistent with gonococcal polyarthralgias, and her pain elicited along the tendon sheath suggests tenosynovitis. The lesion shown in the photograph are typical vesiculopustular lesion of disseminated gonococcal infection. They tend to number from 2 to 10 and may be dismissed as fruncles or pimples. Fever and chills may be present. A history of recent unprotected sex with the new partners frequently associated with disseminated gonococcal infection, while symptoms of symptomatic venereal disease are most often absent. Okay, choice A, arthritis and rash are associated with Lyme disease. The rash, erythema migrans of Lyme disease occurs early on in illness, while arthritis, typically monoarticular knee pain, does not occur until months later. Erythema migrans occurs at the site of a tick bite and has a bull's eye appearance. Tenosynovitis not typical of Lyme disease. Choice B, the skin finding of syphilis include painless ulcer of the genitalia that occurs in the primary stage of infection and maculopapular rash of the palms and soles in the secondary stage. Choice D, meningococcemia present with petechial rash, high fever, headache, nausea, vomiting, stiff neck, and photophobia. This patient specifically denies many of these symptoms. Furthermore, arthritis, tenosynovitis, and the rash in the image are not consistent with meningococcemia. Choice E, the symptoms of acute HIV infection include fever, arthralgia, sore throat, lymphadenopathy, mucocutaneous lesion, diarrhea, and infection. All patients with disseminated gonococcal infection, however, should undergo HIV screening. Choice F, an episode of pharyngitis typically precedes the onset of acute rheumatic fever, include migratory arthritis of the large joints, erythema marginatum, raised ring-shaped lesion over the trunk and extremities, subcutaneous nodules, carditis, and Sydenham chorea. Okay, so now question number 3. A 28-year-old woman comes to the office due to right shoulder pain and weakness. The patient recently returned from a 2-week hike in the Appalachian Mountain and began noticing the symptoms during the trip. She has had no falls or trauma. The patient has no prior medical conditions and takes no medication. Vital signs are within normal limit. Physical examination revealed weakness of right shoulder abduction and external rotation. Passive range of motion is full. Right upper extremity sensation and deep tendon reflexes are normal. The remainder of physical examination shows no abnormalities. Which of the following is the most likely cause of this patient's current symptoms? A. Acromioclavicular ligament sprain. B. Biceps tendon degeneration. C. Borrelia burgdorferi infection. D. Cervical nerve root compression. E. Suprascapular nerve injury.
Acromioclavicular.
Yeah, could be possible. Okay, more answers so that we can check the answer.
I think it's not acromioclavicular. because they are mentioning that there is a weakness of right shoulder abduction and external rotation. So acromioclavicular joint doesn't do this external rotation, and it's with the shoulder joint. So it
It
should
could
be
it
the pathology should be in the shoulder joint. So
could it be
bicep,
suprascapular
What
nerve
about,
injury?
yeah, E?
Because
it,
Yes, E.
it can be, yeah, it can be,
of weakness.
because bicep tender
Because it's causing,
doesn't
also
do
causing
this thing.
weakness.
Yeah, weakness. So weakness
Yes,
is most probably with
yes,
the nerve injury. Yeah.
yes.
Okay. Okay. So it's the answer is E, suprascapular nerve injury. Okay. So yeah, here's a picture showing the suprascapular nerve entrapment. This one like below the, what is it, clavicle, right? Below the clavicle, there's a compression of a nerve at suprascapular notch. This is supraspinatus, and this one is superior transverse scapular ligament. Okay. So this patient most likely has suprascapular nerve entrapment. The suprascapular nerve provides motor supply to supraspinatus and infraspinatus muscle. It originates from the brachial plexus and traverses the suprascapular notch below the superior transverse scapular ligament, which effectively transfers the notch into a forearm. Therefore, the suprascapular nerve entrapment can develop due to external compression of the nerve at suprascapular notch, such as from excessive use of heavy backpack when hiking or commuting. Other causes include a direct blow to the nerve, that is from fall or repetitive motion at the shoulder. Weightlifting, baseball. Clinical features suggestive of SNE at suprascapular notch include shoulder pain, weakness of shoulder abduction, supraspinatus muscle, weakness of external rotation, infraspinatus muscle. Okay, the passive range of motion is preserved. Examination may show tenderness in the suprascapular notch, cross-body adduction of the humerus, which abducts the scapula, may reproduce pain along the top of scapula. In advanced cases, sensory deficits and atrophy of the supraspinatus and infraspinatus muscles may be seen. Initial management includes NSAIDs and activity modification, avoiding the use of backpacks. Choice A, acromioclavicular sprain is usually caused acutely by a fall or a direct blow to the shoulder. As in SNE, the pain may be exacerbated by a cross-body adduction of the arm. However, weakness of shoulder abduction is not seen. Okay, choice B, biceps
Wait,
tendinopathy presents with anterior.
what is this SNE?
Sorry, suprascapular nerve entrapment, like they mentioned before. Okay, choice B, biceps tendinopathy present with anterior shoulder pain radiating to the upper arm. Although the long head of bicep crosses the glenohumeral joint, and rupture may cause partial weakness of shoulder flexion, abduction is not generally affected. Also, this injury is typically associated with noticeable bulge in the anterior arm. Choice C, Borrelia burgdorferi infection, Lyme disease can cause variety of neuropathic syndromes in the early disseminated phase. However, isolated acute mononeuropathy is a rare presentation, and this patient has no other finding. Example, history of erythema migrans, fever, headache to suggest Lyme disease. Choice D, compression of C5 and C6 nerve roots can present with shoulder pain and weakness of abduction, but would typically also cause dermatoma, numbness, paresthesia, and diminished biceps and brachioradialis reflexes. Educational objective, suprascapular nerve entrapment presents with shoulder pain and weakness of the shoulder abduction and external rotation. It can be caused by external compression of the nerve at the suprascapular notch. Example, use of heavy backpack or direct blow or repetitive motion at the shoulder.
ओके, एक चीज मुझे समझ नहीं आया, जैसे उन्होंने कहा SNE पेन में भी
हाँ,
एक्सप्रेस बाय क्रॉस बॉडी एक्सप्रेस, तो ये मतलब SNE में होता है कि नहीं होता है?
होता है क्योंकि वो बैकपैक जो है अगर आप पहन रहे होते तो मोस्ट प्रॉब्ली जो है वो आपका ये सुप्रास्कैपुलर नॉच वाले एरिया को प्रेस कर रहा है, जिसके नीचे आपकी ये नर्व आती है.
ये कौन सा क्वेश्चन बैंक कर रहे हैं आप लोग?
uworld.
ओके।
Okay. So koi can please somebody read question number 4?
I can read.
Okay.
A 44-year-old woman comes to the office due to pain, tingling, and numbness in her hands for the past several months. Pain, tingling, and numbness. The patient says that symptoms are worse at night, so often takes ibuprofen or soaks her hands in warm water to get some symptoms relief. But her wrists and fingers are stiff and painful again by next morning. The patient has difficulty doing morning course, but feels better by midday. She also has excessive fatigue. The patient has no prior medical condition and takes no prescription medication. Temperature is 37.6, blood pressure is 118 by 72, and pulse is 68. BMI is 28 kg per square meter. Physical exam shows the bilateral wrists and joint of the fingers are mildly swollen and tender. Tapping on the flexor surface of the wrist elicits tingling in the first three digits of each hand. The remainder of the joints are normal. Lungs are clear on auscultation and heart sounds are normal. The abdomen is soft and non-tender, but no hepatosplenomegaly. The patient has no rashes or lower extremity edema. Which of the following is the best next step in evaluation of the patient's symptoms? A CT scan of the chest, a hemoglobin A1C assay, MRI of the cervical spine, rheumatoid factor assay, serum cryoglobulin test, serum vitamin B12 test.
I think rheumatoid factor, because see the condition improve with the course. So it's kind of inflammatory condition, not a degenerative condition.
What about B12?
Yes, I think so. Yeah,
B12,
rheumatoid factor.
but if B12, they do mention about the position and vibration senses. But see, there is involvement of small joints, like the wrist joint, joints of the finger. They are also swollen and tender. The most important thing, like they are improved with the like course. By the midday, she feels better. So inflammatory condition, it's like morning stiffness, and with the activity, the pain becomes better. At rest, the pain become more.
Or it's also written that the best next step investigation, like the next step.
Yeah.
But MRI usually is, the last one we do it.
No, I'm saying rheumatoid factor essay.
Okay, rheumatoid.
Option D. Yeah.
Yeah, it can be.
Okay, you read the question, you have to read the explanation also. Like it's your choice. Can you, if you want to read the full explanation, read the full, or otherwise just go with the educational objective.
So here it was like carpal tunnel syndrome, they're saying.
No, the
Oh,
complication of rheumatoid arthritis, carpal tunnel syndrome. So let's divide, like everybody reads one question, and the one who read the question will also read the explanation. Okay?
yeah, what were your key points which you selected for this rheumatoid factor assay? Okay, now moving to the question number 5. A 68-year-old woman comes to the office due to 1-year history of right leg pain. The pain has a relatively constant severity and has not responded to over-the-counter medications. The patient has also experienced intermittent headaches over the last 6 months. Medical history is notable for hypertension, diet-controlled diabetes mellitus, and acute cholecystitis, for which she underwent cholecystectomy 5 years ago. Her current medications include amlodipine as needed acetaminophen. The patient does not smoke and she drinks 1 to 2 alcoholic beverages a night. Vital signs are normal. The hip and knee have normal range of motion with no gross deformity. X-ray of skull reveals areas of bones resorption and sclerosis. X-ray of leg reveals cortical thickening and mild bowing. Which of the following are the most likely findings on the laboratory evaluation? Okay. They are asking about the laboratory investigation, like what we will get. If the patient is having this scenario, so what will be the findings?
Okay, let's first think what is the diagnosis. So yeah, right leg pain with the 1-year history. And the pain has relatively constant, okay. And intermittent headaches. Could it be
She's
like
also
some
drinking alcohol also.
Could it be something like hyperparathyroidism? Like, remember there's a thing called groans, moans, psychic moans, something like that. Stones.
Yes, there was a syndrome of 3. Yes, I got it.
Mhm.
Okay, what likely be the, if you just look at this picture, so what, because the age is also 68,
Yeah.
calcium will be
So
definitely a bit low.
yeah. So I think calcium should be high. Calcium should be high, and yeah, hyperparathyroidism. High alkaline phosphatase. Urine hydroxyproline should be normal, I think so. How about option B? If high calcium, then phosphorus will be low, right?
Yes, high, then here is low, and urine hydroxyproline is normal over here.
Yeah, I think that let's go with option B. Oh
E,
no,
which is calcium is normal,
calcium.
phosphorus also
Phos-
normal, alkaline phosphatase is high, and urine hydroxyproline is high.
What is the
She's having
Oh,
diet
pages.
control diabetes also, and she underwent cholecystectomy, hypertension, amyloidopathy. See, it's also showing the X-ray of the skull reveals bone resorption and sclerosis.
Yeah, there is
Bowing,
lesions. Yeah. The diagnosis is
it's
Paget's
Paget
disease. Okay.
disease, yes,
Okay.
in which we see the bowing of legs.
Yeah, bowing of legs.
Okay, the most important point, see, we usually think that Paget disease, it appears early in the age, but it's most of the patients are asymptomatic.
Yeah. And yeah, the diagnosis at late age.
So the in patient disease, we will get calcium will be normal, phosphorus will be normal as well, alkaline phosphatase will be high, and urine hydroxyproline will be high. Calcium and phosphorus normal, phosphatase and urine will be high in the patient disease. Okay, clinical features of patient disease is most patients are asymptomatic, and there is bone pain and deformity. Skull usually have headache and hearing loss, spine, spinal stenosis and reticulopathy. Long bones usually having a bowing, fracture, arthritis, and giant cell tumor and osteosarcoma, which is very common also. Okay, pathogenesis is osteoclast dysfunction, increased bone turnover. Laboratory testing is elevated alkaline phosphatase, elevated bone turnover markers such as PINP and urine hydroxyproline. So we can get 3 tests elevated. We will get it's alkaline phosphatase, urine this, and PINP. Calcium and phosphorus are usually normal, which we just read. Okay, imaging X-ray shows osteolytic or mixed lytic and sclerotic lesions, which we saw here because the X-ray, resorption and showed sclerosis as well. So it was present. Then bone scan shows focal increase in uptake. Treatment is usually biphosphonates. This patient has the typical features of patient disease of bone, including bony pain, deformity, and mixed lytic sclerotic lesions on X-ray. Patient disease is characterized by disordered osteoclastic bone resorption of uncertain etiology. Paget disease can cause focal enlargement, weakness, or fracture of bone. Bowing of long legs, bone pain, and arthritis in adjacent joints are common. Involvement of cranial bones may cause frontal bossing, headaches, cranial nerve dysfunction, and hearing loss. Was this patient having any kind of headaches? Yes, she was having headaches also. Okay, headaches and hearing loss is very common also, and bowing and legs and fractures. Okay, due to increased bone turnover, serum alkaline phosphatase is elevated and often greater than 10 times the upper limit of the normal. Paget disease is most common cause of asymptomatic elevation in alkaline phosphatase in older patients and often discovered on routine laboratory testing. So she was 68 years old. She was an older patient. And again, alkaline phosphatase, it's usually asymptomatic. Alkaline phosphatase is also seen. Okay, urine hydroxyproline is derived almost exclusively from the breakdown of collagen, and levels will be increased in patient disease as well. Urine calcium may be increased. Urine calcium will be increased, but as we saw above, the blood calcium was normal. However, serum calcium and phosphorus level will be usually normal in the absence of any other complicating factors. Example, prolonged immobility and hyperparathyroidism. The choice A, multiple myeloma can cause osteolytic lesions on X-ray along with hypercalcemia and laboratory evidence of bone turnover. However, bony sclerosis, bowing, and cortical thickening would not be seen. Okay, we saw these three. That is why we are excluding, and the above one was high, and all the above will be high, means serum calcium, phosphorus, alkaline phosphatase, and urine hydroxyproline. That must be in multiple myeloma, because hypercalcemia is seen over there and increased bone turnover, which increases the alkaline phosphatase. Okay, now choice B is elevated calcium, low phosphorus, elevated alkaline phosphatase can be seen in primary hypothyroidism, but urine hydroxyproline is commonly elevated, not normal. Elevated calcium, low phosphorus, and elevated alkaline phosphatase would be seen in this, but urine hydroxyproline is commonly okay. If all the above are high, then it's then primary hyperparathyroidism. Okay, choice number C, hypercalcemia in the setting of normal phosphorus and alkaline phosphatase level may be observed in milk alkali syndrome, which is due to ingestion of large amount of calcium and alkali, that is calcium carbonate. Hypocalcemia with hypophosphatemia suggests hypoparathyroidism, which is which is most commonly seen following thyroid or after neck surgery. Potential manifestations include paresthesia, carpospasms, and seizures. Normal calcium, phosphorus, and bone markers levels would be seen in osteoarthritis. Okay, in osteoarthritis, we will see calcium will be normal, phosphorus will be normal, and normal bone marker levels. Patients may present with musculoskeletal pain, but radiological finding which we confine to joints and periarticular bone. Educational objectives: patient disease of the bone is characterized by disordered osteoclastic bone resorption. Serum alkaline phosphatase and urine hydroxyproline levels are increased due to increased bone turnover. Serum calcium will usually be normal in absence of other complicating factors.